So what I've been studying in the last years is how AD co-pathology or Alzheimer's disease co-pathology influences dementia with Lewy bodies in terms of the clinical presentation, the disease progression, and sometimes also atrophy rate in the brain. And we have found that actually when patients have both co-pathology, they present different clinical presentations. So when we define dementia with Lewy bodies, we usually use core features that had to be present, and the frequency of those core features depends or varies the percentages if you have AD co-pathology or not. We have also found that dementia with Lewy bodies influences disease progression because people that have AD co-pathology have faster disease progression rate than patients that don't. And they have different features in terms of regional brain atrophy. And it seems like AD co-pathology adds to the heterogeneity because when we also did an analysis to identify different clusters or subgroup of patients with dementia with Lewy bodies, and when we analyze AD biomarkers, we show that the presence of AD result in or influences our ability to identify these different subgroups. So I think we have to be aware of this. And this is also very important for the design of clinical trials, because maybe for clinical trials, we will need to stratify in terms of the presence or absence of AD co-pathology in order to analyze the results. We usually use the consensus criteria, but I am hopeful that with new biomarkers for the detection of ɑ-synuclein, we will be able to include in the ATN criteria that is used for Alzheimer's disease another biomarker, in this case for ɑ-synuclein, to be more sure that the patient have deposition of this protein. And we also have in the CTAD conference a poster about that. We are using one of these assays to identify ɑ-synuclein in CSF, and we will be showing these results, these preliminary results.